Hello everyone. I am Aseel AlFahhad, a medical intern accepted at Dermatology, a Riyadh joint program at King Fahd Medical City. And today I'll be talking about vitiligo in a very superficial way for interns and medical students. And I'll be talking about definition, epidemiology, pathology, clinical features, diagnosis and differential diagnosis, and finally the treatment. So by definition, the term vitiligo is believed to be derived from a Latin word, which is vitium, which means defect. Actually, vitiligo, it is an acquired disorder characterized by circumscribed depigmented macules and patches that result from the loss of a functional melanocyte. So basically, vitiligo is a depigmented lesion, and you have to focus on that. It's not a hypopigmented lesion because there's a loss of the functional melanocyte. Epidemiology, it affects 0.5 to 2% worldwide. It affects both genders equally. It can occur anytime after birth to late adulthood. The average onset is 20 years of age. However, it can occur at any age. The etiology is unknown, but it's known to be a multifactorial, or it's thought to be a multifactorial. There's a genetic predisposition or autoimmune destruction of melanocyte or oxidative stress or intrinsic defect of melanocyte. All of these factors may lead to melanocyte destruction, which will lead to the appearance of vitiligo. So the clinical features, actually it is asymptomatic, but pruritus is occasionally noted, especially if there is an active lesion. At the onset, usually insidious. The color is milk white macules or patches. The shape is either round, oval, irregular, or linear shape. The borders is well demarcated, and actually it could be ill-defined shape at their onset or when actively spreading, but at the end, it's a well demarcated lesion. The size range from millimeters to centimeters. It enlarges centrifugally, slowly or rapidly. The site, it may develop anywhere on the body, but interestingly, it is frequently localized to the sites that are normally relatively hyperpigmented, such as the face, the dorsal hand, the axilla, the umbilicus, the nipples, groin, and genitals. If it's facial vitiligo, usually occur around the eyes and mouth. In extremities, elbows, knees, digits, wrists, dorsal ankles, and shins. Areas subjected to trauma or pressure or friction, especially bony prominence. This is a known phenomena. It's known as a coblenization. Coblenization means after trauma, there will be a lesion at the site of the trauma. Here you see a Kobner phenomena at the lesion site, and the site more vulnerable to friction or pressure. It may occasionally start as a multiple halo nevi. It also may affect the hair on the scalp, eyebrows, eyelashes, and body, and causing leukotrichia or biliosis. This is leukotrichia and biliosis. Actually, in vitiligo, normally pigmented hair is the main source of the repigmentation, since they are the most important reservoir of melanocyte in this condition. But here, the patient doesn't have a normal pigmented hair. So therefore, this patient, if there is leukotrichia, The possibility of repigmentation is minimal or null because the hair melanocyte loss is usually permanent. So this is considered as one of the poor prognosis for vitiligo. Also depigmentation في الريتنا معي أكثر. Clinical classification. The following classification divide vitiligo into two major types, either localized or generalized vitiligo. The localized is focal, which means one or more macules in one area, but not in segmental distribution. Or segmental, which means one or more macule involving one or rarely multiple segments of the body, and the region are typically unilateral and stub in the midline. Here, stub in the midline. Generalized vitiligo, the most common type is vulgaris. Scattered patches that are widely distributed over the body, or acrofacial on the hand and foot, or universal. The most common type is vulgaris and acrofacial variants. As segmental vitiligo, this type is more common in children than adults. The clinical variants of vitiligo include vitiligo puncto, which is characterized by small, discrete, confetti-like, melanocytic macules scattered over his body. Or inflammatory vitiligo, which is vitiligo macules or patches with erythematous raised border. This type can be associated with mild pruritus and can be misdiagnosed as tinea corporis, which is infection, fungal infection. The third variant is trichrome vitiligo, and the name say trichrome, which means three color, and here you can notice a third intermediate layer or color between the depigmented lesion and the normal skin. And we also have quadrichrome vitiligo, which is another variant, in which there is a fourth color at site of perifollicular repigmentation. Here is a hypochromic vitiligo, which is a very rare form of vitiligo, and usually it is common for dark-skinned people, skin type 5 and 6, characterized by the presence of hypopigmented lesion with or without a depigmented lesion. This is a blue vitiligo, which is, as you see, blue-gray appearance of vitiligo macules, usually observed in areas of post-inflammatory dermal pigmentation. The course of the disease actually is unpredictable. Lesion can remain stable or progress slowly for years. Flare-ups are common and may be separated by stable period. Generalized vitiligo spreads slowly, but it may stabilize for a long period of time or evolve rapidly, rarely total body involvement within few weeks or even days. But segmental vitiligo reach its full extent within 1 to 2 years and remain restricted to the initial segment area. Factors that indicate a poor prognosis, such as long duration of the disease, family history of non-segmental vitiligo, Koebner phenomena, leukotrichia, as I said earlier, and mucosal involvement. The lesion considered stable when there is no change detected in a 12-month period. Clinical markers of disease activity include trichrome lesion or Koebner phenomena, or inflammatory lesion, or confetti-like depigmentation. The diagnosis, the diagnosis of vitiligo is clinically and straightforward, based upon the clinical finding of acquired, discrete, well-demarcated, uniformly white macules with well-defined border, surrounded by normal skin in the absence of inflammation or textural changes. You may ask a question that helps you in the history, such as the age of onset, factors or events that may have preceded the onset, associated symptoms, progression or spread of the lesion, changes observed in the lesion over the time. The diagnosis of vitiligo may be facilitated by the use of Wood's lamp. This is the Wood's lamp, which is a handheld device emitting ultraviolet A light, especially in individuals with pale skin. Under the Wood's light, the depigmented area will emit a bright blue-white fluorescent that appears sharply demarcated. It will appear sharply demarcated and a blue-white in color. The pathology, a skin biopsy actually is not routinely required for the diagnosis of vitiligo, but maybe if there's a questionable diagnosis, they may ask for pathology. We can see melanocytes are absent here in the pathology. Laboratory studies, vitiligo is known to be an autoimmune disease. So we do a screening for other autoimmune disease, such as autoimmune thyroid disease. Differential diagnosis include pityriasis alba, which is a common hypopigmented scaly patch seen in sun-exposed areas, especially in children, or pityriasis versicolor, which is a fungal infection characterized by scaly hypopigmented macules on the trunk, or idiopathic guttate hypomelanosis, which is multiple hypopigmented macules on the sun-exposed area, common in elderly. Nevus depigmentosis, which is a well-defined area of depigmentation present since birth and early childhood, which doesn't enlarge and require no treatment. Chemical leukoderma, which is loss of skin pigment due to contact with chemicals. Associated disorder, so as I mentioned earlier, it is an autoimmune disease. Usually it is associated with other autoimmune disease, especially thyroid disease or Addison disease, type 1 diabetes mellitus, or pernicious anemia, and all the other autoimmune disease. Treatment, actually we have two aims at the treatment. The first is to stabilize the depigmentation process, and the second is to repigmentation. The best response areas are the face, neck, mid extremities, and trunk. And the resistant areas include distal extremities and depths. After therapeutic repigmentation, the rate of recurrent depigmentation of the vitiligo lesion is 40%. So after we did a repigmentation, there is 40% that it will depigment again. So the optimal treatment depends on a lot of the optimal treatment depends on the subtype of the disease itself, the percent of the body surface area involved, the effect on the quality of life. So some patients, they don't want treatment. They are okay with the vitiligo and they don't want, and the other patients are depressed and they require a treatment or extensive treatment. We have a lot of choices, starting by topical, then phototherapy, then systemic, then surgical, then depigmentation treatment. Topical treatment include corticosteroid cream. The potency depends on the site, either daily or twice daily application in cyclical fashion with some days off. So we can use it 1 week on and 1 week off, or 5 days on and 2 days off. Why we do it in cyclical fashion? To decrease the side effect. What is the side effect? Cutaneous atrophy, telangiectasia, hypertrichosis, acne and striae, and steroid folliculitis. calcineurin inhibitor, such as tacrolimus ointment. It is the first line for head and neck lesion, used twice daily. First line because they have less side effect than corticosteroid. They will not cause atrophy. So we can use it in combination with topical corticosteroid on the days off. So when we use the corticosteroid for 5 days, we use calcineurin inhibitor in the remaining 2 days. Phototherapy refers to treatment with ultraviolet radiation. The indication include extensive disease and rapidly spreading disease. It works on vitiligo by 2 mechanisms: immune suppression, preventing the destruction of the melanocyte, or stimulation of the cytokines. This is a picture before and after phototherapy. Systemic therapy, many pulses of oral steroid for 3 to 6 months, such as dexamethasone, 2.5 to 4 milligram, 2 consecutive days per week for 3 to 6 months. Methotrexate, cyclosporin, oral minocyclines, and subcutaneous afamilnate. Surgical treatment, usually for stable and segmental vitiligo. It required removal of the top layer of vitiligo skin by either shaving, dermabrasion, sandpapering, or laser, and replace it with pigmented skin removed from the other side of the body. Here you can see a picture, and this after bunch grafting. We have a lot of surgical technique. We have other modality of treatment, which is depigmentation. This is used for patients with recalcitrant and widespread disease, more than 50% of the body surface area. We use monobenzyl ether of hydroquinone, which is the most commonly used in depigmentation therapy, and only drug approved by FDA. Only considered after psychological screening and informed consent. Why? Because it has an irreversible effect. It will cause irreversible whitening of the body. It's applied in a 20% concentration twice daily to the pigmented skin, and care should be taken to avoid excessive sun exposure, which can result in perifollicular repigmentation. The most side effect is irritant contact dermatitis. Complete repigmentation may require 4 to 12 months of therapy, with potentially longer duration required in patient with skin color. If no response after 4 months, the concentration can be increased to 30%. Treatment should be discontinued if there is no response at 6 months. Once depigmentation is achieved, it can be used a few times per week as a maintenance therapy. Here you can see treatment outline. You can take a screenshot. With this, I end up with my presentation. If you have any question.
يعطيك ألف عافية دكتورة على presentation. It was very clear. If anyone would like to ask a question with Victoria, you can use the chat or you can use the Q&A, and I'll be happy to read them out. Doctora, may you please would you please repeat what the segmental vitiligo mean again?
So segmental vitiligo's type of localized vitiligo, and it means one or more macules involving one or multiple segments of the body, but usually unilaterally and stop at the midline.
كمان دكتورة, one of the attendees would also like you to return to the treatment slide. They'd like to screenshot it.
Okay. This one?
Yeah, I think she meant this one.
So thank you all for your listening. This is my references.
يعطيك ألف عافية دكتورة.